last talk. This is a bit more talk what I think rather than what it is or what the evidence says. Again, I apologize for the font differences. Is somehow my PowerPoint and your PowerPoint's a very different version. So I've been asked to think about, can we extend it from thrombolysis beyond 24 hours? As I said, this is just my own thinking with some evidence around, but there is no evidence yet. No COI. Is there actually evidence for salvageable tissue beyond 24 hours? Let's go back and have a look at some of the evidence. Firstly, it actually came with Greg Albert, diffuse 3. He actually looked at his diffuse 3 data and saw that at the 24 hours there were patients who had perfusion deficit. And there were patients without perfusion deficit. But the patient who had perfusion deficit, as you can see here, if they have perfusion deficit, their outcome at 3 months is actually worse. You ask why? It's because after 24 hours, there was no treatment. So this perfusion deficit or penumbra continued to die and led to worse outcome. In fact, patients did not have perfusion deficit at the end of 24 hours, did okay because they have no more tissue to die. So that gives us the first evidence that at 24 hours, this penumbral tissue still matters. And he also, that's a graph to show that this, what I call the ultra-late penumbra, actually leads to worse outcome because there was no treatment. Then we look at the frequency. Obviously, there's no trial yet beyond 24 hours, so we don't have that details, but this graph shows it's a law of diminishing return. As the time went on, your penumbral mismatch existence reduced over time and become less and less. And to me, I think they become even less and less clinically significant because the salvage of it does lead to clinical outcome better, but probably not as much as an early time window. I'll explain that a little bit later. So is there any insight from the current trials that we can do things beyond 24 hours? This is a table I constructed just for this talk, putting up all these trials. Unfortunately, TNK plus got cut off at the end a little bit. So you can see this mainly including trials from early time window to very late time window. So if you look at, unfortunately again, the boxes section mismatched. Anyway, look at extend and wake up, and then look at trace, and then the later time window. What you can see, there is a progressive increasing sample size as you went on to later time window. One would expect that because, as I mentioned before, the mismatch existence is becoming less. And I suspect that the effect size also may become less because these are what we call slow progressor, which we'll talk about a bit later. And then you look at imaging. The extended time window, they all had perfusion imaging, advanced imaging, compared to early time window. And then you look at the positive and the negative trials. The major differences in the late time window, the difference between positive and negative trials are, did they have thrombectomy or not? The trials of the patient, the majority of them had thrombectomy, were negative trials. Then you look at effect size. The early time window and the late time window are very similar. And even the negative trials are very similar. I think this is in fact more related to the initial stroke severity rather than the time itself. If you can see, the higher the NIHSS on emission, the smaller the effect size. So therefore, I think it's more related to stroke severity rather than time. And then you look at, oh, that's what I did, sorry, I was one step ahead. So yeah, emission NIH is more important outcome factor. And then we look at TNK and TPA. I think in all time window, they're very compatible, the outcome. So they're very similar. And then you look at adverse outcome. I think if you look at across the whole range, the symptomatic ICH and mortality are very compatible in the early and the late time windows. And the severity is more related to the outcome, the adverse event is more related to stroke severity rather than time. So to me, at this moment, I think 0 to 24 hour window, thrombolysis is certainly better than best therapy. Both TPA and tenecteplase are similar. As the window widens, the sample size increase. The effect size looks broadly consistent, but I think it's actually diminishing with time. Initial stroke severity largely drives the outcome, favorable outcome and unfavorable outcome. Positive results emerge only when thrombectomy was not performed. And in fact, what evidence covers thrombectomy patients with a larger sample size help? Let's look back at the beyond 24 hours, where is the evidence right now? There's a recent meta-analysis of 10 observational studies, which are not RCTs, looking at thrombectomy beyond 24 hours. It shows better functional independence, but higher intracranial hemorrhage rate, but no difference in mortality. So certainly from observational studies, thrombectomy, we're not talking about thrombolysis, thrombectomy seems to benefit. So therefore, there is definitely salvageable tissues. And what then I start thinking about, what do we need to know to actually have an effective thrombolysis beyond 24 hours? I think the first thing is collateral, because you've got a core and then you've got a penumbral tissue, and what's important thing is a collateral that's sustaining the penumbra up to 24 hours and beyond. And that's one of the crucial things. So we all know how to access collateral by multiphase CTA, and you can see the good collateral with a lot of blood flow through the vessel and the intermediate less, and the poor collateral bottom one, which is very poor collateral, basically no blood flow. And we know from earlier on, from thrombectomy trials, that Mr. Clean did not actually use perfusion imaging while diffuse extent they all used. So therefore, with time, we realized that they were all called fast progressor and slow progressor. Fast progressor are the rapid infarct expansion patients, and they usually have very poor collaterals, while the patient with slow progressor usually have better collaterals. And you can see in this graph, most of the fast progressors are in the first 6 hours, and the slow progressor is pretty flat up to 24 hours. And I suspect that you're actually going to see more beyond 24 hours. And as you can see, the fast progressor, usually core is much larger by the time you even image, 70 mil. And the slow progressor, even up to 24 hours, the core usually less than 30 mil. So they've got a good collateral to sustain the penumbra. And then if you look at this early time window, if you look at all patients from the top, as time went on, your probability of good outcome reduces. But if you look at the fast progressor on the right, the probability of good outcome dropped rapidly. And then, but you look at the slow progressor, over time, the good outcome actually didn't change at all on the left. So that's sustained by the collateral. And then with better collateral, such as you actually have a much bigger penumbra. You can see the patient has good collateral score, they have a much bigger mismatch ratios, meaning that they're sustaining the penumbra. And with good collateral, you actually get better outcome, such as imaging aspect, they have higher aspect score. 24-hour core is smaller, 24-hour aspect is better. In fact, they have better recanalizations, and 90 days MRS is actually better in patients with good collateral compared to poor collateral. That just tells you how important collateral is. Why I'm saying so important, because that's what you need up beyond 24 hours. I'll probably skip this slide. This is just the way we actually assess infarct growth rate. But the other thing beyond the collateral, I want to look at the core. I believe the core changes with time. A core beyond 24 hours is not the same core under 24 hours. So we all thought when you do your assessment CD perfusion, it's one big blob of red. It's all the same tissue. It's not. If you look at particularly coming from the large core trial, the core is heterogeneous, meaning that there are dead tissues, there are salvageable tissues, there are potentially slow progressing tissue, fast progressing tissue. There are many different types of tissue within the core, not just one thing. And in fact, CD perfusion in late time window can overestimate the core. As you can see, this patient got a large red core, but in fact the final infarct was barely minimal there. But it can also underestimate the call. You can see in this case, there's just no call at the start, but in fact, you've got a large infarct at the end. And in fact, in the late time window, you get many different types of call. You get non-contrast call, a 5% relative reduction in intensity of call, CBF call, and final infarction. None of them actually match a final infarction. As time went on, the equation gets more complex. And in fact, for thrombectomy and thrombolysis, because thrombectomy is so much more effective, the thresholds actually should be different. A patient receiving thrombolysis, the threshold for CBF call should be 30% compared to 30% of ECR group. Even that is different. So therefore, I do believe with time, our threshold should change and get more complicated. And in fact, if you look at angel aspect, the angel aspect group look at it, their mismatch only really relevant and predict outcome in less than 6 hours. In 6 to 24 hours, beyond that, it actually didn't really predict outcome, the mismatch. And in fact, this is a very nice graph. Looking at from onset time to CD perfusion time, the actual ability of the infarct call predicting outcome reduces. It only really matters early time windows. As time went on, the ability of using CD perfusion call to predict outcome actually gets less and less and less. So the question then becomes, should we actually use that for beyond 24 hours? And in fact, I think someone here also published this paper in looking at patients who actually have no penumbra, actually still respond to thrombectomy. You say, well, there's no penumbra. Why do you respond? Because the core is heterogeneous. The core still has penumbral tissue in there. And in fact, the odd ratio is 7.33. It's massive, even though you don't have a mismatch. And in fact, the Dawn group using clinical mismatch, meaning the NIHS is more than 10 with aspect, it's more than 7, and then NIHSS of more than 20 and aspect more than 5, this clinical aspect mismatch performed as well as CT perfusion aspect. So what it means is that CT perfusion in the late time window may not be as relevant or as accurate. And in fact, if you look at this late time window in large call, the aspects call probably just do as well as a CD perfusion call in the late time window. I'm stretching this late time window, not early time window. But it's not all good news. So this study just looking at why don't we just use simple CT imaging to assess call before thrombectomy. It performed nearly as well, but it actually has a lower detection of large vessel occlusion and higher hemorrhagic transformation risk or rate compared to CD perfusion. So it is somewhat compatible, but still not performing as good as perfusion scans. But let's go even one step further. Let's look at the CT scan and the perfusion scan together. In fact, we all experience, when we look at a CT scan, there are some really dark area in the core, but there's some not so dark area. Is that a difference? There is. If you actually map out the relative intensity of the CT area and match it with CD perfusion, these are areas that the less dark area probably do have penumbral tissues. And this study looking at the relative hypointensity, it's 1.8% reduction in penumbral area and 3.3% reduction in the core. Meaning that you're right, when you see very dark CT, it means dead tissues. But what it also means that not the whole aspect you call is all dead tissue. And in fact, there's a new technique we're also involved in, is net water uptake. Net water uptake CT is probably pretty good for late time window call. And if you look at the patient here, aspect of 4, net water uptake of 17, 52 ml of so-called core volume, MRS of 4 at 90 days. If you look at the other so-called aspect 4, both are aspect of 4, but net water uptake is only 6%, 113 mil, much bigger core, but MRS2 at 90 days. So in fact, because the net water uptake, which is edema in the tissue, is less, it means there means still penumbral salvageable tissue in the second patient, despite a larger volume core. I'll skip that. So therefore, if you look at the net water uptake emission percentage, it's actually correlate with MRS outcome at 3 months. And there is now some automated software to look at net water uptake on CT scans. But I want to throw a little bit more into it too. In fact, as we all know, as the infarct tissue progresses, your blood-brain barrier breaks down. As your blood-brain barrier breaks down, you start to have contrast leak. So if you actually see contrast leak into the core, it means this is very, very dead tissue. And there are high rates of potential hemorrhage transformation and poor outcome. So now we're also starting to look at blood-brain barrier breakdown. You can actually look at yourself. If you do perfusion scan or CT angiogram, ask them to do a post-contrast CT at the end. And if you see contrast leak, it means there's a blood-brain barrier breakdown. I do it all the time at my hospital. So in fact, if you look at this study, look at blood-brain barrier breakdown, each 1% increase in blood-brain barrier disruption, the odds of poor functional outcome increase by 16%. So this is all this new information can tell me who to thrombolyze in the very late time window. So the ultra late time window, this is becoming my own interpretation, what I think it is. I think it's very different to early time window. I'm not talking about 24 hours. I'm talking about ultra late beyond 24 hours. The perfusion imaging is required for every positive late time window study, except wake up, which is using DWI. But which threshold parameter are correct remains uncertain. I do believe what we use in early time window is probably not translatable in very late time window. It still probably make a positive trial, but probably we're actually misidentifying some of the patients. We need to balance both risk of hemorrhage, which is the core, and the penumbral tissue benefits. So we need to find out what's the best way to identify the core and the penumbra. Probably we do need a combined approach of many different ways. We still need further studies. But the problem is, we all know thrombectomy is extremely effective. To prove thrombolysis, it's having additional benefit over thrombectomy, you will need a very, very large sample size. I don't think it's not going to work in bridging therapy, but you need such a massive sample size to prove it that I don't think it's feasible to do a study on. The other thing I mentioned earlier is law of diminishing return, meaning that in the ultra late time window, you could have fewer and fewer and fewer patients. It will take longer time to recruit. With a larger sample size, you do need, quite a lot of patients and a very big study to prove that it works. And also, as you saw before, the late time window patients are usually what we call slow progressor. They usually have smaller mismatch, the clinical severity not as much. To show the power difference from treatment, no treatment, will take even more patients. So I do think thrombolysis more as a complementary role. Mainly for patients with large vessel occlusion, thrombectomy performed after 24 hours is likely to be very effective. A TPA or thrombolysis only add a few as a complementary thing. And even in ultra late time window, thrombectomy, I believe, remains the advantage over thrombolysis. With this ultra late time window, thrombolysis are probably matters most as a bridging, and for those who are ineligible for thrombectomy. The other thing is how come a non-LVO presentation this late time window, we don't know. But I also think we need to know about the collateral status. We also need better thrombolytics. Currently we've got TPA and TNK, they're both pretty good. But I think we need better one to actually get into this ultra late time window. So my prediction is, this is my last slide, Beyond 24 hours, I think thrombolysis is going to be effective. It's going to be proven positive. But we're mainly helping slow progressor of these patients. And some of these patients, they may do well with them without thrombolysis. And mainly if we're effective or proven effective, meaning the patient is LVO and do not undergo thrombectomy. I think that's where the trial is, and I think that's where Carol is heading. I think she's going to have a positive trial. But establishing efficacy after thrombectomy, we need an extremely large sample size. I don't think it's not going to work. I think the patient will benefit from bridging therapy, but you need a massive sample size to prove this. I think the most important thing right now is get the right imaging thresholding and real imaging modality, because I don't think the current threshold we're using for CTP core is actually correct. I think for late time was very incorrect. Maybe there are other things we actually add on to. So thank you very much.
Thank you very much for a very great talk.